There are two speakers today. The first speaker is going to be Professor Christophe Fraser, who's a professor of pathogen dynamics at Oxford's Big Data Institute. And I'll be the second speaker. My name is Michael Parker. I'm a professor of bioethics in the Wellcome Centre for Ethics and Humanities. So without further ado, I'm going to hand over to Christophe. We're going to speak each for about 10 minutes, and then we'll have 10 minutes for questions at the end. Christophe.
Thank you very much. So very happy to be speaking to you today. So I'll talk you a little bit through the underlying scientific rationale for contact tracing, and in particular for using technology, for using apps for contact tracing, and some of the sort of predicted effects and design considerations. So since March, so we've been analyzing the COVID epidemic really since its beginnings in China and then in global spread. And since March, we've been closely collaborating with NHSX, a branch of the NHS, in terms of developing a contact tracing app and really focusing on the scientific basis for this approach, and in further work in terms of the scientific understanding of what these apps are and should need to do. So the first findings that we made available through preprinting in February, and that were published a little time on, were our analysis of the different routes of transmission of the virus first in China, based on the early published findings, and in Singapore and Hong Kong and other settings. And what we tried to do is through looking at the transmission pairs and the transmission events that were actually found in the early days of the epidemic through contact tracing, we quantified in this curve here, this is an average, a summary over several studies, the sources of different types of transmission. So this is if you follow an average individual or a cohort of individuals over time on the x-axis over a number of days, the different contributions to transmission. There's statistical uncertainty around this, which is hard to show in this kind of picture, and which is detailed in our publication with the reference here. But broadly, we found that about half of transmission occurred through direct transmission in this light blue area during the first few days of transmission, and really peaking sort of in the 2 days leading up to a person developing symptoms. So this was sort of maybe the most surprising finding, and it's been reproduced now through about 20 publications and follow-up of many more transmission events, especially in households. So in dark blue, you see the transmission from individuals directly through symptomatic transmission, and a little bit of transmission from people who never go on to become symptoms. So there's to develop symptoms, so truly asymptomatic individuals. And the most uncertainty we had is really about the role of environmental transmission, shown in light green, with the virus surviving for some time on surfaces. So the two distinguishing features of COVID that differentiate it from many other respiratory pathogens is this extensive transmission just before people develop symptoms, and the potential for environmental contamination, as was seen sort of right back at the beginning of the epidemic. So putting these findings together, we then modeled the process of contact tracing. So contact tracing was an intervention that was used at the start of the epidemic to try to control the early outbreaks internationally. And we saw that with these data, we'd modeled other infections such as SARS in 2003 and Ebola. And this transmission during pre-symptomatic sort of transmission before people get symptoms is particularly problematic for the success of contact tracing. So if you imagine a sort of a chain of events where you start infected and then you start shedding virus here, the infectious virus shown in green, and you're infectious, and you then infect somebody else. If that happens before you develop symptoms, contact tracing is a process of starting from a symptomatic individual, and then either direct contact tracing or waiting or testing them, so that you can let the people they've infected know. And the idea there is that if you let them know, they can self-isolate or quarantine, and then this person who's been infected, they have advance notice that they've been infected, so you can reduce the probability that they infect to others. And the problem with COVID is all of this happens rather quickly. We've sort of about four or so days between a person really being aware that they've got distinctive symptoms, and one problem is the symptoms are not always that distinctive, and then having to find that person before they infect other people. So we had the idea, sort of looking at this timeline, that if you could speed up the process through a contact tracing app, that would really help you get ahead of this process. And so what we did is we modeled this contact tracing app, and we showed, under a simple idealized model, that it could be very successful, and that was our first finding. And since then, we and many others have developed much more realistic and detailed simulations to look at all of this. But the way it works is, if you imagine a group of people meeting over the course of a day, and then here one of the people develops symptoms, and they either self-report symptoms through the app and request a test, and then if they receive their test rapidly, then if the phones have a memory of the other phones which were running an app, so here persons B, C, and D, and those contacts were sufficiently close and sufficiently long, then at this point when the person receives a test, or possibly initially upon symptoms, these people receive a notification that they were exposed. Now that notification then needs to make sense within a public health system in terms of being part of the policy. So at the moment, the policy in the UK, when you receive a contact tracing notification, is to quarantine for 14 days. Now, obviously that message can also be passed through manual contact tracing, and is reliant on a fair number of people running this app. But when you look back at the race against time, that the time saved through this process can be quite valuable. And also these people may have been in close proximity, for example, on public transport, and may therefore not be able to recall each other through manual contact tracing. So since this sort of conceptual work, many organizations, including the NHS, have been developing the apps, and we've been simulating the utility of the apps in a post-lockdown, when people go back to social and physical mixing, and you might get an increase in transmission. So the transmission rate, many of you will have heard about the reproduction number, is how many people you infect on average. And this shows, if we went back to original mixing levels, and what the reproduction number might be after the lockdown. Now, the interesting thing is, of course, that different interventions will sort of act together, and you can see that if you're reducing, so one of the interventions is people self-isolating and quarantining themselves and quarantining household members if you get sick, which is why the reproduction number is lower now than it was in sort of February. But then you also have additional social distancing, and the aim is to keep social distancing such that you keep this reproduction number below 1. So you can see here, as I toggle through the picture, you reach the point where the reproduction number can be kept below 1 by using a mixture of social distancing, and of course it's easier if you have a high uptake. The other thing is that throughout this range, any sort of amount of app uptake is going to be very helpful in terms of contributing to reducing the reproduction number, as is manual contact tracing and so on. In this picture, I just want to show you the point that if you translate this reproductive number into incidence, being able to reduce the reproductive number close to 1 really makes a huge difference in terms of mitigating the possibility that we face a second wave later this year of the epidemic here in the UK. and that impact, any degree of progression and increase in app uptake is going to be helpful. So you can really quantify the impact of using the app, and that's essentially that if you're an app user, on average, you're going to cause a third less infections than non-app users with this intervention. And we can show that in these simulations, one way of thinking about the effect of these apps is that for every 1 to 2 app users, you can prevent 1 onwards infection. If, in this scenario where the epidemic is starting to increase again towards a second wave. One of the features of this is the speed at which this happens is critically important. So this is just showing you for a given uptake of the app, the predicted cumulative deaths on the left and the cumulative rate of new infections on the right, showing you that you have this race against time. And this is true both in terms of, we're now looking at manual contact tracing and app-based contact tracing together, that the effect of testing delays is very significant, and it's really worth remembering always that basic picture that you have about 4 days from somebody really realizing that they have reporting the distinctive symptoms before the person they've infected starting to be infectious. So one possibility, and we've modeled this, one possibility which you can do with app-based contact tracing that you can't do, or is more difficult to do otherwise, is you can send multiple exposure notifications. So here showing you that you could have an amber notification telling you that you've come into contact with somebody with suspected symptoms, and that we recommend, being a bit more cautious before you have the quarantine notice based on test positive symptoms. But that needs to take place in the context of a social pact where we understand that the symptoms are not that specific, and you may receive those kind of notifications on the basis of false positives, which are then stood down as people have test results. And one of the features, of the deployment in the UK is, and we've seen this from the pilot that has been run over on the Isle of Wight in the last month, is that there's a lot of trust in the NHS, and this system run within the NHS is fairly high uptake, more than about 50%, more than 50% of smartphone users on the Isle of Wight. There's lots of discussions going forward, which Mike will discuss about the trade-off in between privacy and the public health utility of saving lives and enabling us to move. And we've seen different choices being made. Google, Apple, sort of focusing on a system which is global, which maximize or increases privacy on the spectrum. And some of for example, the French app, which has a very strong legal process that went through Parliament, which collects more data because of perceived epidemiological utility. And those trade-offs are sort of subject to ongoing discussion. The dynamics of COVID transmission supports the use of rapid contact tracing. Digital contact tracing does give you that speed. Contacts need to be notified before they infect others. But it's worth remembering and thinking in the context of our privacy and regulation that it needs to be integrated with other public health measures. In particular, as we're seeing in the UK, integrated as part of a test, trace, isolate policy, but it can be highly effective and very scalable in terms of preventing another surge in cases. And we really want the app to be understood as a public health intervention. So thank you very much to my research group and collaborators in terms of the funders, and particularly the Lily Cashing Foundation in supporting this work. And our many collaborators in the NHS and internationally. And I'll pass over to Mike.
Thanks very much, Christophe. For those of you who have questions, please do post those in the chat, and we'll get to those. We'll get to those later. So what I'm going to do now, in the time allocated to me, is to set some of that discussion in context, and as Christophe says, to raise some ethical questions related to contact tracing. So the first slide is really just to emphasize the importance of context when we're thinking about the rationale for the use of these mobile phone apps, but also when thinking about the ethical aspects of their use. So just, I don't think I need to go through this in detail, but just to emphasize the huge numbers of deaths and the amount of suffering that is happening and has happened around the world, and to emphasize the fact that we're actually at a difficult and dangerous time at the moment, where many countries, not all, but many countries are starting to think about opening up after the lockdown. And one of the important questions is, well, how do we decide to do that? How do we manage to do that? And what are the different considerations that need to be taken into account? So as I say, we're at a difficult point, and there are many competing considerations and commitments that need to be taken into account. Of course, one of those is saving lives and reducing suffering. So we've got a public health concerns. We've got concerns beyond public health, for example, those relating to education of children. We've got economic considerations of equity, considerations relating to protecting valuable public institutions. So that might be the health service, it might be financial institutions and others. We've got concerns about social capital, so communities, families, religious organizations and events, for example. So we've got concerns about future generations. For example, the level of debt that's incurred, and questions about personal freedom. So we've got a whole range of these things that are pulling in different directions and might lead to different decisions about how to open up from a lockdown. And the key thing here is that as we do open up from a lockdown, we need to do that in an intelligent way. And the problem with lockdowns as currently practiced is they're a very blunt tool. So we start to see an increase in infections, and we impose a general lockdown. That achieves, as we've seen, important public health goals, but it does so at a very high cost. And one of the advantages of thinking in a more intelligent way about social distancing is that it might help us to address health threats whilst better promoting these other values. So we may not need to close down schools, for example, in all areas of the country, but close them down in locally appropriate ways. And contact tracing is a key tool for the use of that process. Contact tracing is important because it can enable us to identify the emergence of dangerous clusters, and it can enable informed public health response to deal with those, but also promote socially responsible choices for individuals. It's important, as Christophe mentioned, to remember that there are two types of contact tracing. So one type of contact tracing is that what's sometimes referred to as manual contact tracing. So this is where a person with COVID-19 is contacted by public health authorities, required by law to give information about all of their relevant contacts, and that might include their phone numbers, addresses, and so on. And then those data are entered into a data set or database, and public health officials contact all those other people and ask them or require them to self-isolate or test. So that's one approach. And for example, in the UK, we've just set up 20,000 contact tracers to do this kind of work. The other kind of contact tracing is contact tracing by mobile phone app, which Christophe has described, so I won't go into detail about that.
It's not seeing your slides, Mike. Sorry to interrupt.
Okay, I don't know what's happening there. Let me just see what I'm. Apologies. Let me see what I'm. Apologies, everyone. Let me just go to where I was on this. Thanks very much, Christophe. Okay, so both of these two approaches to contact tracing, manual contact tracing and mobile phone app contact tracing, both involve the gathering of data that wouldn't be acceptable normally outside the context of dangerous infectious diseases. So all contact tracing requires that, and all lockdowns involve restrictions on liberty, but most people would accept that these are necessary to address the risks in public health emergencies, but they need to be proportionate. So any restrictions on liberty need to be minimized as far as they can be, and so does the gathering of personal data. And there needs to be a careful balance between privacy and liberty in these kind of situations. One of the questions we might want to ask in the context of mobile phone apps, given that the fact that there are these two approaches to contact tracing, is to ask whether there's anything ethically special about mobile phone apps. Both of these approaches to contact tracing use data to identify clusters and inform interventions. Manual approaches use very specific personal data gathered by law, and apps gather data about proximity events and send notifications, usually voluntarily. So the first question, the most important ethical question, I think, in relation to both of these is, can they make a contribution to saving lives? And if they can, it seems there's a strong argument in favor of using them. One of the choices Christophe mentioned in his talk was between the different types of apps that are available, the range of different possibilities, including the Google, Apple model, but also others. And it seems to me there are important questions we need to ask when we're thinking about which of those to choose. So one of them we might want to ask is just how good are they at identifying clusters and informing the interventions that we want to see happen to save lives? The second question is going to be how much data do they collect, and is that data proportionate to the goal? A third aim would be, how can it be integrated effectively within a broader public health response, given the points I made earlier about the need to have an intelligent health system? Then there'll be questions about accountability, about the uses of data, how are data used now and how might they be used in the future? And then finally, questions about how much choice is there for a user in each of those situations? How can we maximize choice? It seems to me that there are a number of ethical requirements for the use of mobile phone apps to be ethically acceptable. It seems to me there's a strong argument if apps can contribute to saving lives and reducing suffering, there's some strong prima facie obligation to use them. Unless there are other considerations, it seems to me we should use these. But there are also other important ethical considerations. So the first is that there ought to be independent, transparent, and inclusive oversight of the use of the app. There ought to be a clear agreement about when the app's use will stop. So what counts as the end of the emergency? There ought to be transparency about the algorithm and the ways in which data are going to be used now, but also agreement about the scope of any acceptable future uses of data. And then there needs to be a commitment to equity throughout, so people should be treated fairly. And coming back to the point I made earlier, it's also important that any imposition on liberty and privacy is minimized and is compatible with addressing the public health threat. So inevitably there is some imposition on privacy here, and inevitably there is some imposition on liberty if we're going to have targeted lockdowns, but those need to be fair and compatible and appropriate. So I think there are a number of important ethical considerations that need to be addressed for this to be fair. But one of the most important ethical challenges, I think, for me is the question about what should happen with data at the end of the use of this app in the context of an emergency. So one way we might go about building public trust now and encouraging lots of people to use the app, which is what Christophe argued is important, will be to make a promise that at the end of the emergency, all the data will be deleted. And if that's required for trust, then that might be the right thing to do. But I think there are other questions, and it's not ethically unproblematic. So it's notable that in many countries, and the UK would be a good example, we were very poorly prepared for COVID-19 when it came. And it seems to me it's vital that we learn from this experience for future and how to deal with future epidemics. So there's at least some argument to be made that some of the data should be retained in a depersonalized way, and it should be used for future research under carefully governed conditions. It seems to me that we have got obligations to future generations, and that might place on us an obligation to save at least some of this data and to do research on the data to help us be better prepared in the future. So thank you. Apologies for not sharing all of my slides with you, but I hope you got a sense of what I was saying there. And so what we're going to do now is have some questions. And I'm going to start off, while I'm checking which questions have come in, I'm going to start off with a question for Christophe about the use of the app. Christophe, so one of the things I think some people might ask is, once we've got these apps out in the world being used as part of public health response now, how are we going to go about in practice evaluating their effectiveness and learning whether they're doing the job that we want them to do?
So it's an interesting question because, and this is a very typical problem in public health, which is that a successful public health intervention integrates the different public health measures. So we're increasing testing, we're increasing clarity of messaging around social distancing, we're increasing manual contact tracing, and increasing the use of the app-based contact tracing all of the same time. So in public health, for these kinds of situations, we talk about sort of intervention packages. And when you have an innovative intervention such as this, being able to separate out that effect can be quite difficult. And of course, you can compare different areas, where the uptake is different. But you can, through simulations that are carefully calibrated, in terms of the uptake and the function, and comparing those and checking that those are predictive, you can disentangle the effect of different interventions. The other thing you can do, which is interesting, is that the app works on a social network. So you can sort of either randomize or record. You can ask people to say, how do their friends, how many of their workplaces use the app, or ask people to encourage their social network to use it, and then you can make side-by-side comparisons. But I think it's very important when you have an intervention such as this, and that's discussed as much, to think about ways of doing that. That's going to be a critical part of the intervention.
One question which has just come up on the chat is actually probably applicable to both of us, but I'll ask it you first. Is one of the questions is that we're seeing, as because of the emergency, we're seeing a very accelerated timeline and lots of pressure from government, but also from elsewhere to make these things happen. How do you, as a scientist, cope with those pressures? I mean, what impact does that have on you and the media attention as well?
Well, so I think it's a lot of scientists. I would probably be similar to lots, but not all scientists, in saying that media is not a natural environment for speaking, and we tend to speak cautiously and emphasize uncertainties, and we should continue to do that. But I think it's important, when our work becomes relevant to an international crisis, for us to articulate our work. So we've I think it's part of our responsibility to reach out and do that work, and communication of our science. So and in an infectious domain, when we work in policy relevant areas, that's things we have to do. And like everybody else, we put in the extra hours. How about yourself?
Well, I think one of the great things about this process, from my point of view, has been the unique opportunity really to think about ethical questions from the start. When we had that first conversation about this, it's extremely unusual for an ethicist to be involved in science that early. But obviously that's fed through the development phase in the UK, and actually some international conversations too. And the pressure's great, because you can't do things in the slow kind of reflective way that one's used to as a scientist or as an ethicist. So there's a lot of pressure there. One of the questions which relates to that, one of the questions in the chat line was about how in the UK we've ensured that liberty and privacy have been taken into account. And I think we're still in the early stages of developing the app, but we've done a number of things to try to help that. One of the things we've done is set up an independent ethics advisory board, which is overseeing some of this process. The use of the app in the UK is voluntary, so that's an important part of this. I think there are arguments to be made, and someone might want to make them, but I won't make them here, to say that there ought to be stronger encouragement for people to use this. If we're used to the idea of contact tracers coming around by law, getting information manually off people, and in context of emergency, maybe there's a strong argument for the use of the app in a more required way as part of public health response, where that's really shown to have an effect. But maybe that's for a future discussion. It looks like we've just got about a minute left. So Christophe, do you have any kind of final thoughts?
So you laid out the sort of dilemmas around future research use of the data. What are your personal sort of opinions on the necessity for that work?
My personal view is that public trust and confidence are really important for this to work, for just in terms of practicalities, but also the right thing ethically. But I think we really need a sensible conversation as a society. Just in the same way as we think about climate change as being something where we have an obligation to future generations to act in ways that may not be in our individual interest now, but for the future. I also think sharing our data might be a similar kind of consideration. With appropriate protections, I think there might be obligations to make sure that we contribute to future lives and the reduction of future suffering. So, I would be in favor of that given the right kind of protections, but others will of course disagree with that. It looks like it's 1 o'clock, so here in the UK, so I think we're supposed to stop now. Thanks very much, everyone, for listening in and for watching. Apologies I didn't share my slides, but hopefully you got enough of what I was saying for that to make sense. We can perhaps make sure my slides are available online. Just a couple of things about the video. When the video is available online, you'll see that below that, there's a link for you. If you're interested in supporting our research, you can do that there. But you can also see the details of the next COVID conversation, which will be in the next few days. So please do take an opportunity to take a look there. And thanks very much again for joining us today.
Thank you very much.